This will be going over your airway assessment. If you need a review of airway anatomy, make sure that you go back and look at that respiratory anatomy or airway anatomy presentation as well. So when we're talking about airway, typically we actually approach it as kind of a respiratory problem. And respiratory problems can exist in a very wide range of presentations. So we could have something from mild dyspnea, which is just, maybe a little bit short of breath, but still perfusing fine. We may have severe dyspnea, which is where we're having what we typically consider to be respiratory distress. They may have 2 to 3 word dyspnea. They may be tripoding. They may have some wheezing, coughing. Especially in pediatrics, you may have some accessory muscle usage. Other things that we're looking for are going to be hypoxia and exhaustion. Now, what this means for us is going to be respiratory failure. A lot of people get failure and arrest mixed up. Failure can still be breathing. What it means is that the respiratory drive is failing to meet the needs of the body, either to perfuse or to remove waste products. So failure can still be breathing, but they're not breathing adequately, so they're going to need assistance. And then, of course, the one that most everybody recognizes, respiratory arrest. So this is where you have your agonal respirations or your apnea altogether. Now, some signs of the differences between your distress, failure, and respiratory arrest. So in normal breathing, 12 to 20 times a minute, distress usually is going to be normal, but maybe a little bit outside of the normal range, like say if you went and ran around a building real quick. Respiratory failure is going to typically be 30 or greater, which is usually harder to recognize, or 8 or less. And most people are pretty good about recognizing the 8 or less. Also, tidal volume there is important. It's going to be shallow, inadequate tidal volume. With respiratory arrest, you're going to have agonal or absent respiratory rate. Now, your tidal volume, like I said, for respiratory arrest, it's going to be minimal to none. For failure, it's going to be inadequate. Usually we'll see this as shallow. For respiratory distress, it could be increased or decreased. And then normal breathing, adequate depth, free movement of air there. Now, your breath sounds, normal breathing, no abnormal sounds, right? They're present, equal, bilateral. For distress, you may have any kind of funky so all kinds of funky noises. We call those adventitious. So anything adventitious just means abnormal breath sound. For failure, ditto. You have the same things. You may have any number of different adventitious sounds. And then for respiratory arrest, they're not breathing, so we don't have any. We have absent breath sounds. Now, for your work of breathing, normal breathing, of course, is normal. Respiratory distress is slightly to moderately increased. Failure is increased, but they are showing signs of fatigue. And then respiratory arrest is minimal to absence. Appearance is really important here as well. For normal breathing, they should have a good skin color. For distress, they usually look kind of anxious. May show some mild signs of hypoxia, but usually still look fairly normal but distressed. Respiratory failure, they're going to be anxious. They're going to show cyanosis usually. And level of consciousness or responsiveness may start to decrease, and they may be confused due to the hypoxic state. Respiratory arrest, decreased to no responsiveness, and then profound cyanosis sets in pretty quickly. Now, these abnormal breath sounds, snoring, this is that kind of harsh vibrating sound. It could be loud or soft. And what this is, we all recognize as a partial obstruction of the upper airway by the tongue. So what we need to do for this one, 9 times out of 10, head tilt, chin lift, right? Kind of, because what happens is that airway kind of collapses under its own weight when they are lying. Gurgling, we recognize as fluid somewhere in the upper airway. Stridor is that really harsh sound, and what this is a partial upper airway obstruction. Could be from edema, foreign body, could be epiglottitis, several different things that can cause it. Of course, coughing, everybody knows what cough is, and this is irritation of the respiratory mucosa. Wheezing is like that whistly sound. Usually we're looking for it on expiration, but it can be heard on inspiration as well. And we know this is the narrowing of the bronchioles from edema or from bronchoconstriction. Now your crackles, got the fine bubbly noises. To me, this sounds more like the crackles of like if you ever put a record player on, and you put a record on and play it, and the little parts in between the music, the popping staticky noises, to me that's what that crackle sounds like. But this is fluid in the smaller airways, the lower airways, and the alveoli. Alright, now rhonchi, that coarse liquid airway sound, that's to me like the milk bubbles. You're blowing milk bubbles like with a straw in a cup of milk. it's big and coarse sounding, and these are secretions of the bronchi. Could be pus, could be fluid, could be a whole number of things. So, when we're talking about upper airway problems, there's a lot of different things that can cause these. Some of your more common ones are going to be decreased level of consciousness or responsiveness, and what happens is when you have that decreased level of responsiveness, you lose muscle tone. And so when you lose muscle tone, that tongue kind of just flops back, and some of those airway structures kind of collapse upon themselves. Okay, you've got some like 14, I think, different muscle groups that control airway, so if you lose any of that tone in any of those, it can lead to a potential obstruction. If you have a patient, usually when we look at snoring, they're going to be supine, but you can also have some upper airway problems if they're seated positionally responsive, because if they lean forward, then they could actually potentially occlude part of their trachea as well. Foreign bodies are fairly common, if not the most common, airway obstruction. And what happens is anything that goes in the airway that's not supposed to can block off that airflow. Sometimes we are called because the patient choked on food, or kids put something in their mouth and inhaled it. Sometimes we get called because somebody had a stroke or a drug overdose or something happened and they vomited and their stomach contents are now aspirated into the airway. So a lot of different things there that can cause the airway obstructions. There may be active bleeding if they're a trauma patient. They may have blood clots, or they could even have direct injury to the airway structures themselves. You know, your trachea is primarily made up of cartilage rings. So if those cartilage rings get broken, that's going to impede the airway there. Now, your lower airway problems. These are going to be things obviously below the trachea. So here the big things are going to be a bronchoconstriction. You know, that could be from a bronchospasm, like say if it's a reactive airway disease, asthma, something like that, or inflammatory response, whether it be from asthma or cystic fibrosis or chronic bronchitis or whatever might cause, you know, that chronic or acute inflammation there. Now, when you have fluid or pus in the alveoli, you know, such as like with pulmonary edema, pneumonia, things like that, not only is it blocking part of your bronchiole, so you're going to have a narrowed airway there for air to exchange, but it's also going to affect actual gas exchange and the external respiration when it's in the alveoli, because we don't breathe well underwater, right? So we can't exchange gas well when there's things, fluid or pus or anything like that, that's in the way. You know, it kind of disrupts the closeness, if you will, of the oxygen and the capillary membranes that are wrapping around the alveoli. Problems, essentially. Those are problems with the tube that brings air in. We also have to look at, is there a ventilation problem? Because we know with respiratory, you got to look at patency, airway patency, but also the mechanical part of it, the ventilation. Is the body able to ventilate? So anything that interferes with the body's ability to move the chest wall or the diaphragm and generate that negative intrathoracic pressure impairs ventilation. This could be paralysis of the respiratory muscles, you know, if they've had a stroke or if they have spinal cord trauma, something like that. Any kind of trauma that disrupts the chest wall, the integrity of the chest wall. So, you know, a gunshot wound to the chest wall, you're not going to be able to create a hole there. You're not going to be able to create that negative pressure to pull in the air. Okay. Anything that causes a disruption to the trachea or the bronchi, if you have a ruptured trachea, you tend to die fairly quickly because all air coming in is going to seep out through that ruptured trachea. Okay. And then anything that causes your body not to send the signals out. Remember, that signal comes from the medulla. Well, if there's something going on that slows your nervous system, like say a stroke or drug overdose or something like that, it can depress that respiratory center and then result in hypoventilation, eventually apnea. So every patient that you encounter should be evaluated in both the scene size up and primary assessment, looking for airway problems. Because remember, ABCs, right? The goal of this evaluation is just to rapidly identify anything that's life-threatening immediately to their airway, to their ventilation, or to their oxygenation. When you find a life threat, you fix it. Simple as that. You know, a lot of people just kind of skim right over this and don't pay close enough attention instead of actually getting in there and doing a good, thorough assessment. We're going to get additional information about the breathing and things like that during your secondary and your history. His primary initial is just getting the immediate life threats. the additional information that helps you determine what specific treatments may be needed. So, for instance, like at the EMT level, a lot of times they're taught if they're having problems breathing, give them oxygen, give them oxygen, give them oxygen. Well, at the next point, we're looking at not everybody just needs oxygen. Now, if they need oxygen, you don't withhold it, but not everybody needs high-flow oxygen. Some of your COPD patients don't need high-flow oxygen. If your problem is an asthmatic patient and they're having bronchoconstriction, do they need oxygen? Probably. Do they need something else? Absolutely. They need an albuterol inhaler, right? They need a beta-2 agonist to help open up those bronchioles, because you can put all the oxygen to them you want, but if you don't fix the underlying problem, it's not going to do any good. Right? Same thing with like pulmonary edema. You got to help fix the underlying issues, get that fluid out of the airway in order to be able to help the patient there. So we're seeing size up. Things we're looking at here. General impression. All right, there's a lot of clues that can help you kind of figure out what's going on with their current condition, but focus on the patient themselves and get your general impression. All right, you'll see a lot of different information all at once, but you've got to be able to prioritize your attention and figure out and focus on what is going on. So whether they are obviously responsive or obviously unresponsive. How do we do that? We look at them, we talk to them, right? And we decide, are they responsive or unresponsive? Then we're going to look for any signs of injury or distress. So if they're responsive, this may be a little bit easier, or it may be even harder. It just depends on what's going on. But we're going to look at the position they're in, how they're sitting. Are they tripoding? Are they leaned over? Are they slumped back? Any indications for distress or injuries like bleeding, pale skin, active seizure, anything like this. The more you do it, the faster you will recognize respiratory distress. It becomes almost like second nature, but you've got to go through it in a systematic approach, especially when you first start, so that you can learn those signs and symptoms to recognize those very quickly. Right? Usually your severe distress is going to be pretty obvious. Right? And so things you're looking for there: increased effort to breathe, the use of your accessory muscles, abnormal breath sounds, tripod position, cyanosis, things like this. Any of those things that you see should go, oh, hey, I need to focus on this airway and breathing a little bit more. Some other things we want to look at, like quality of their speech. Are they hoarse or scratchy? That could be a partially obstructed airway, or it could be one that's about to close up. All these things we've got to find and identify during this primary assessment. So when we have an apparently unresponsive patient, these are the patients that are going to be cyanotic. They're mottled. No effort, agonal breathing, which agonal breathing is an ineffective, shallow, and irregular gasping. Think like a fish out of water. They have that kind of guppy breathing going on. So if you see that, that's typically going to be considered agonal breathing. Okay, so when you have a patient who's unresponsive and has absent or abnormal breathing, the next step is to check a pulse. Check a pulse. Check the carotid pulse because they're unresponsive. Right? If you cannot detect a carotid pulse in 10 seconds, they're in cardiac arrest. Start compression, start CPR. Okay? Not everybody who is unresponsive, though, is actually unresponsive. They may be asleep. I've seen some people sleep really hard. They may be intoxicated, or they could be having some other kind of medical or trauma problem that doesn't allow them to respond. Okay? They may respond to loud voice commands or painful stimulus, or they may not respond at all. Okay? If they awaken when you provide verbal or painful stimulus, then you approach that assessment like you would a responsive patient. They're no longer unresponsive, okay? And if they respond in any other way other than becoming alert, like if they withdraw from pain or something like that, but they don't really open their eyes, look at you, interact with you, then make sure that airway is open and evaluate the breathing and circulation very carefully. Okay, so of course, when we are opening the airway, if we do not suspect cervical spine injury, head tilt, chin lift, right? If we do suspect spinal injury, jaw thrust, right? Which, if you've never done the jaw thrust, it sucks. It's hard to do well, and it's hard to maintain. It will wear your fingers out. So make sure that you are doing it appropriately if you're going to do this. Now, if you do have somebody with a suspected cervical spinal injury, it's relatively contraindicated for a head tilt, chin lift, meaning, if you cannot adequately manage that airway with a modified jaw thrust, you've got to remember, if they don't have a patent airway, they're going to die. So you may have to choose between some movement of the spine to establish an airway or not being able to establish an airway. Always choose to establish your airway, but do it reasonably and cautiously. Before we can move on to breathing, we have to make sure that the airway is open or patent and is going to stay that way. So we've done our head maneuvering if we need to. The next step is to look and see if the airway contains any fluid, blood, vomit, anything like that. We're going to suction. Okay, we're going to suction to clear it. Then we're going to do something to try to make it stay patent. So if they are unresponsive still, then you might want to consider an airway adjunct, so an OPA or an MPA. Okay, of course, OPAs, if it's an OPA, then we're not going to put it in there if they have a gag reflex. That would mean we would go to a nasopharyngeal airway. And if they have a potential for a basal skull fracture, we would not do an MPA, we would do an OPA, right? So we're going to assess for breathing. So to assess for breathing, look, listen, feel, okay? Like we already said, if they aren't breathing or don't have a normal breathing, you check the pulse. But if the pulse is absent, you start compressions. But if that pulse is present, open the airway. Make sure the airway's open, assess the breathing. So look, listen, and feel. We're going to kneel down. We're going to turn their head to the side, looking for any chest movement, abdominal movement, listening to see if they're moving. And look at the chest wall. Does the movement there indicate adequate tidal volume or decreased tidal volume? All right, are both sides of the chest moving symmetrically? They should be. If you're not sure, put your hand on their chest wall to feel. Feel for that movement. All right, does the rate seem fast, slow, normal? All right, listen for air movement at the mouth and the nose. Try to determine volume of airflow. Okay, you can also use your stethoscope to listen for the presence of breath sounds. Just listen for one inspiration and expiration at one location on the anterior side of each chest. Then listen on the other side. Okay, if this breathing is inadequate or absent, use BVM to assist their ventilations or to provide artificial ventilations. Right? If the ventilations are obstructed and repositioning the airway does not help, you need to think about a foreign body airway. After we do this, we move on to our circulation. So during that primary assessment, we're going to check the carotid pulse to determine its strength, rhythm, and whether that rate is slow, normal, or fast. You may be asking yourself, why are we talking about circulation in the airway? Well, what does circulation show us? Signs of perfusion, right? So when we're looking at this, besides just the normal rate, rhythm, quality, and coloration, or stopping the bleeding, look at the coloration as well, because if they are showing signs of poor perfusion or hypoxia, it could be related back to an airway issue. Now, going back to our responsive patient, okay, a responsive patient who has an open airway and is breathing and has a pulse, we're going to look a little more closely at, is there an immediate problem with the quality of the ABCs, or is there something going on underlying? So one of the first things we're going to do is look for your signs of hypoxia, okay? Look for any signs of or indications of respiratory distress, like your accessory muscle usage, positioning, things like that. Listen for your abnormal breath sounds. All right, we are going to determine their chief complaint. What do they think is the main problem? Right, look at the quality of speech. Are they able to speak a full sentence? They should be able to speak a full sentence without having to stop and take a breath. Okay, that's not normal speech. Look and listen to their breathing patterns and their airway. All right, and look for those indications of your respiratory distress. Now, when we are assessing these patients and their airway, a couple things we're looking at. The goal here is, of course, to find any immediate life threats. And if they have any immediate life threats, to intervene and provide treatment for those. So typically, the best approach for managing an airway is going to be going from simple to complex. We don't want to jump ahead and try to put a supraglottic or an ET tube in them when we haven't even opened that airway yet. They may not need it once we open the airway. So always start simple and work your way up. Okay? If simple airway management techniques provide an airway, ask some additional questions. Do you anticipate that these techniques will remain sufficient? Or what are the risks or benefits of additional actions? If they are managing the airway with a head tilt chin lift, what could possibly happen if we put an OPA in? They could gag and then they could aspirate, so it could get worse. So we may not need to go any further. Okay? If simple techniques do not provide adequate airway, then you got to recognize that and then select the next more advanced approach. What needs to happen next? Okay? The best approach here is the one that provides an adequate airway with the least risk for the patient. And sometimes that means you won't do anything beyond a manual maneuver. Sometimes you'll have to use a simple airway adjunct. Sometimes you'll have to use an advanced airway adjunct. Sometimes none of the things you have available to you will provide an airway, and you've got to recognize that and go get advanced care. Take them on to the hospital to get some help and do the best that you can meanwhile. All right? So any and all patients with a complaint of dyspnea or any indication of impaired ventilation and oxygenation need supplemental oxygen. Now, how much depends on the patient. One of your determinations in your primary assessment is whether the patient is in or at risk for respiratory distress or failure. In order to recognize this and make that decision, you've got to anticipate kind of a course of events, what's going to happen next. So sometimes the best approach for this is to find the underlying problem so hopefully you can correct that underlying problem so the patient can manage their own airway and breathing rather than assuming you should immediately go to more aggressive interventions. And this is where that information from the secondary assessment can really help you determine if there's a specific correctable underlying cause for the respiratory problem. So a good little kind of model here, clinical decision making, general impression, level of responsiveness, and level of distress. So if they're responsive, assess the quality of the airway, the breathing, and the oxygenation. If they have inadequate breathing, assist those ventilations and then give them supplemental oxygen. If they have adequate breathing but adequate oxygenation and adequate oxygenation, leave them alone. If they have adequate breathing but inadequate oxygenation, give them supplemental. If they are unresponsive, check breathing and a pulse. If they have no breathing and they have no pulse, start CPR. If they have breathing and a pulse, check for responsiveness. Okay, if they have decreased responsiveness, maintain airway, check breathing. If they're adequately breathing, give them oxygen. If they're inadequately breathing, positive pressure ventilations and oxygen. Okay, if they were responsive, go to assessment for a responsive patient. And if they have a pulse but no breathing, establish your airway and begin positive pressure ventilations with oxygen. So it breaks it down pretty simply there. It's a pretty good little chart. Now, when we're looking at our respiratory, the primary assessment is just kind of an overall overview of the presence and adequacy of breathing. So it's not the end-all be-all, but it gives us that immediate life threat recognition. So it's real important with our secondary to make sure that we do a very detailed secondary assessment, because we want to make sure that we're finding any underlying causes of anything else that could happen or that could be going on. Now, with our secondary assessment, we're going to be looking for some specific rates and patterns. Okay, a lot of times abnormal patterns can indicate some kind of metabolic or neurological problem. When you are assessing your breath sounds, remove or loosen as many layers of clothes as possible so that you can accurately assess your breath sounds. Try to keep modesty and warmth and all that stuff, but you're not going to be able to listen to breath sounds appropriately through clothing. You're going to get interference there. All right, so you're going to listen to one side of the chest, then move your stethoscope to the opposite side in the same location. All right, breath sounds should be present equally on both sides. The lung fields are going to go as high as the shoulders and can reach as low as the umbilicus during inspiration. So start with your auscultation towards the upper chest and back and work downward to find the bases of the lungs. Normal breathing should be free of funky noises and should be fairly quiet. If you're having trouble hearing those breath sounds, have them open up their mouth and take a breath like that instead of just through their nose, because then you get more air movement if they're able to follow commands there. Now, some of your funky kind of patterns here. Regular in and outs can be eupnea or normal. All right, increased rate is going to be tachypnea. Decreased rate is going to be bradypnea. Absence of breathing, of course, is apnea. Are you seeing the nea part? That is your breathing. That's referring to the breathing. Of course, tachy we know is fast, brady means slow, and a means without. All right, now normal rate but deep respiration is going to be hypernia. Your gradual increases and decreases with periods of apnea, this is going to be a Shane-Stokes. Okay, so this is more associated with your brainstem injuries or intracranial pressure. And it's almost like a respiratory version of torsades, the way it builds up in crescendos and decrescendos. Your BIOTS is going to be rapid and deep respirations. These are more gasping with pauses between the sets, and this is usually going to be some kind of neurological damage, neurological cause. Your Kussmaul's is going to be fast and deep, and this is usually associated with some kind of acidosis, most commonly diabetic ketoacidosis, but it can occur with other acidosis as well. And then apneustic is you have a prolonged inspiratory, so you're, and then a puff out. So it's just usually that is a problem in the brainstem itself. Now, some other things we're looking at during that secondary, we're looking at that rate itself. Normal adult respiratory rate is 12 to 20. Keep in mind that pediatrics do vary based on their age. Okay, we want to make sure that we auscultate our breath sounds. We want to look at our, we want to evaluate our pulse oximetry. A normal pulse oximetry range is between 95 and 100% at lower geographical elevations, and higher altitudes are like 90 to 100, so it goes a little bit lower. We're talking like Pikes Peak, like Colorado high, not normal, you can still see sea level type high. Another thing to keep in mind too, pulse oximetry, people look at it as the end-all be-all, and it's a great tool, but it's just that, it's a tool, it's not the end-all be-all. Some of the problems with pulse oximetry is that, number one, it does not measure what is bound to hemoglobin. It just looks that something is bound to hemoglobin. So some things can cause false high readings with your pulse oximetry. Additionally, it only measures what's there. So let's say you've lost half of your blood volume, okay, but all of the hemoglobin that's there is still bound, but it's going to give you a falsely high reading because you're still missing half of your blood volume. 95% of 100 milliliters is pretty good. 95% of 50 milliliters is not going to give you quite the same, right? Capnometry, measurement of that carbon dioxide. Normal values here, 35 to 45. Fantastic and underused tool. If you have questions, don't quite understand that, make sure you go back and look at that capnography and capnometry presentation. Some good information there, and it's a great tool that is coming around, but people still don't use it quite as much as they could. All right. After we get our good assessment, we're going to compare ongoing findings to our baseline values that we obtained in that primary and secondary assessments, and continue to reassess, looking for things, did what we do work? Is there something else that we need to do? These patients that are in respiratory distress can rapidly progress to respiratory failure. It's very important that you are vigilant and look for these changes so that you can adjust your treatment as needed.